Welcome to ATCM, the Emergency Medicine Channel. A 68-year-old male patient was brought to our ER with complaints of fever, cough, breathing difficulty, abdominal pain and chills for the last 3 days. Initially, he was admitted in outside hospital. From there, he was referred here for further management. On initial 10-second assessment, airway was patent. Patient was able to speak in full sentences. Breathing-wise, patient was already on non-invasive ventilation on BiPAP from outside. With the saturation of 98% with an FiO2 of 100%. Then respiratory rate was 24 per minute. Chest-wise, patient had bilateral creps, inframammary, infraaxillary, left more than right. Coming to circulation, patient's BP was 180 by 80 with a pulse rate of 124 per minute. Disability-wise, GCS was E4, V5, M6, pupils bilaterally equally reactive. Exposure-wise, temperature was 97.9 degree Fahrenheit with GRPS of 125. At this point,
188 by 88.
180.
Do you see something there or it's okay?
This is just technically because on the higher side.
So what we'll do now? Do you want to correct it or
As
it's
of
okay?
now, patients have shifted. We want to evaluate the BP after half an hour. Coming to adjuncts to primary.
Somebody is having high BP and breathlessness. What is the first thing it will come to? So you have to look for that. If the patient is in heart failure, if you don't try to control the BP, what will happen? Already failure is that BP is very high. Heart cannot pump against this high pressure area. So our first priority, then the focus will turn to that side.
So coming to advanced primary survey, we took a CBC-CRP point of care, which showed a total counts of 1,600 with hemoglobin of 10.9.
1,600.
With a platelet of 198.
In that neutrophil, what is the percentage?
Neutrophil percentages
1,600.
for 55%.
So 800 is a neutrophil.
You can see around 825. With the CRP more than 230. It is showing neutropenia, sepsis.
Neutropenia.
It
We
is
have to
showing
see whether it
neutropenia.
is sepsis or not secondary.
Then coming to ABG, we taken an ABG which showed a pH of 7.525 with alkaline with a PCO of 27.7. Respiratory.
Okay.
With bicarb
Carbon
of
dioxide was
22.7.
22.
With a PO2 of 100.
Okay, so it's a respiratory alkalosis you are dealing with. Okay.
No electrolyte imbalance as such. With lactate of 2.9 and creat of 3.09.
Creatinine 3.07 and lactate is normal.
Lactate is 2.9.
2.0.
This was taken in 100% FiO2 on a 9. Then coming to, we also did a lung ultrasound. This patient was having breathlessness with BP on the higher side. Point of care ultrasound showed bilateral mild pleural effusion was there with the minimal B lengths bilaterally.
What does it mean?
It shows the wet lung could be due to any infection, could be due to
Infection or pulmonary edema.
edema.
Okay. So both are possible here because one is he is having high BP, so pulmonary edema is possible. Another one he is having a possible neutropenia, then that infection also possible.
So at this time we are seeing all routine lab investigations including antiprotein. Then coming to sample history, 68
If you can tell what is anti-proBNP, then it will be.
Sir, it is actually a marker of cardiac failure.
What is the value gain?
This patient's value is 328.
328 is not very high, but it's like marginally high. Okay.
Coming to sample
So on one side it is cleared. What is cleared?
cardiac component.
So cardiac component, pulmonary edema, maybe pulmonary edema. That word we cannot take because ARDS is non-cardiogenic pulmonary edema. That is not removed, but cardiogenic pulmonary edema is possibly removed from your diagnostic list.
We also went ahead with an echo for the patient, which showed good L,
Good L.
no RWA.
Okay.
So at that point, we ruled out cardiogenic pulmonary edema.
Okay.
Then coming to the sample history, patient is a 68-year-old male patient who is a known case of type 2 diabetes, hypertension, dyslipidemia, rapidly proliferative glomerular nephritis, IgA nephropathy.
Okay.
Patient was on Azoram.
IgA nephropathy is the most common cause for nephropathy in adults who is not having diabetes. Then that is a common cause. Immune mediated, one of the most common causes is IgA nephropathy. They have IBP, renal failure, chronic kidney disease, they can go to end-stage renal disease.
Patient went to outside hospital with complaints of fever with chills, lower abdominal pain, and difficulty in maturation 1 week back.
You were telling about some drugs he was
on. His regular medications he was on Visolol and also on Azora. As a therapy, he was taking. That was his regular medication. Went to outside hospital with fever, chills, abdominal pain, difficulty in maturation, and was admitted due to worsening of symptoms. Their initial lab investigation showed neutropenia with a total neutrophil count of around 1500. And so he was started on injection piperacillin and admitted in that hospital. They had withheld Azoran, suspecting neutropenia, drug-induced neutropenia, and also.
If you are treating doctor, what will be his first response in this case? If you are the treating doctor there, or suppose you are seeing the patient as a first-hand information to you, when he is coming to your clinic, what is your treatment?
Patients coming in neutropenia.
To you, like this. Nobody has seen prior to this consultation.
Breathing difficulty.
No, that's okay. Leave that.
Like fever. Initially, we have to. If patient is having neutropenia, then we have to stop the offending drugs and then start.
Offending drug is stopped. Next is.
GCS. Start patient with
what antibiotic?
Broad spectrum antibiotics.
Don't tell broad spectrum. Pinpoint.
With MRSA coverage.
What is the treatment you give for a patient who is having neutropenic sepsis? So you start that, rest of the things it will be like Tell me the treatment. So she has seen a neutropenic sepsis with probable pulmonary infiltrations. You have to treat other oxygen, ventilator, all these things we'll discuss. What is the first response from your side? He was on one drug that is stopped, offending drug is stopped. Next is what? Colony stimulating factor you told. Start on colony stimulating factor. Third one is what antibiotic is it? You will start. What antibiotic? Don't tell broad spectrum, then there are a lot of drugs. What you are going to start in this patient, you tell.
In every coverage, antibiotic used.
What is the drug? Differential tazobactam will be an ideal drug to be started initially itself with any other drug. Antifungal coverage you can give. Then third one. So differential tazobactam is a very good drug, very good choice of drug. Antifungal is also should be started. Third one is according to current guidelines, most of the current guidelines. The most common problem in a patient who is taking immunosuppression, PCP. Okay. So most of the time we miss that. We miss that because we have not learned about that. So PCP prophylaxis should be given when you are treating a patient like this, so that can be prevented. And when a patient comes back when he is on chronic immunosuppression, now here it is due to your complete shutdown of immune marrow. That may be the reason. So you have rightly started the present as well. Antifungal as given. But PCP prophylaxis and PCP treatment should be offered to this patient. PCP treatment is same like Bactrim BS drug. If you are giving tablets, 2 tablets TID, they are giving injection, IV 1 dose TID, it should be started. So that has to be there in regime.
Outside, they had a urine culture which showed Enterococcus fecalis, which is sensitive to piptaz.
Do you think that it is a problem? Enterococcus fecalis, we get most of the cultures. It may be a contamination, but here, since the patient is having immunocompromisation, that should be treated. But when you are starting with present tazobactam, that will cover that.
Then, in that hospital, patient developed sudden desaturation with tachypnea and tachycardia.
Okay.
Following which, patient was put on BiPAP. Further, there was worsening of the total counts. Total counts decreased from 1500 to, ANC decreased from 1500 to 900. Antibiotics were escalated in that hospital to meropenem and teicoplanin. And from there, patient...
Teicoplanin is started in your since there is a bilateral infiltration in the line. Next possible is MRSA.
So X-ray outside done there showed bilateral infiltrates, but the patient was further desaturating, so they referred you for further management. Here, after we received patient already ABGY showed PaO2, FiO2 ratio of around 1. So it was with bilateral infiltrates, and we had also shifted the patient for a CT. Initially when patient came, CT thorax showed patient was having areas of ill-defined areas of ground glass opacities in bilateral upper lobes and similar patchy areas along the peribronchovascular markings involving bilateral lower lobes and extensive ground glass haziness in bilateral lung, which is suggestive of ARDS.
Yeah. So ABG and CT shows possibility of ARDS.
Taking it as ARDS, we started the patient on...
So what may be the trigger for ARDS here?
Sepsis already.
Trigger is infection, lung infection or a systemic infection producing lung problems.
So patient in our hospital, patient was started on meropenem. It was continued on meropenem, teicoplanin. Injection AZ was started.
What do you give meropenem? Normal. What is the? It's a ideally, how do you?
24-hour concentration should be maintained.
It should be. It's a concentration dependent killer of bacteria. Ideally, in ideal situation, you have to give continuous infusion. That gives better coverage of like meropenem than bolus doses, because it's not a concentration dependent killer. It's a time dependent killer. But sometimes it is not possible when you are treating in ward and all. It may not be possible because stability of drug is also very important.
We continued on meropenem, azithromycin, teicoplanin, and fluconazole. And we added injection polypitor in suspicion of PCP pneumonia.
Okay. Polypitor is, that's a brand. Polypitor is
Cotranazole.
It's a sulfa drug which is mainly used for PCP pneumonia treatment, and tablets can be given for prevention also.
Then patient was already on 100% FiO2 from outside hospital. In our hospital, in view of further desaturation, we intubated the patient. After intubation, we started the patient on ARDS ventilation, that is low tidal volume, high peak ventilation we maintain. We also started the patient on injection
epidemic. She is telling about low tidal volume and high peak ventilation. It's a classical ventilation you give in ARDS. What does it mean? What are you your understanding? No tidal volume. We are keeping the tidal volume low. So what will happen? So alveolar injury can be prevented. We cannot completely avoid it, but since there is a possibility of alveoli is full of water, exudates. So there is possibility of injury, rupture, or pneumothorax, or these things are possible.
So we started the patient.
But you are keeping PEEP high. So what will happen?
Chances of
Trauma is there, but already some alveoli contains lot of exudates that may not open it up. But since there are a lot of dead spaces in your lung, that can be opened because of the PEEP high.
Then we also started the patient on injection epidemic, which is a basically vasoactive inhibitory peptide, which helps by increasing the number of type 2 cells in the lungs, that increases the surfactants. So it's a new therapy that nowadays we have started using in moderate to severe ARDS patients. Then within hospital stay, patient actually...
Role of steroids?
Role of steroids, we also started on injection hydrocortisone. Role of steroids in early ARDS within 14 days, it is advisable, and especially if patient is having sepsis, any existing COPD, or any patients having any community acquired pneumonia, it is advisable to give steroids. Those can be, we can use either dexamethasone, methylprednisolone, or hydrocortisone. So in this patient, injection hydrocortisone was added. Patient also developed hypotension. So we have to start the patient on inotropes.
What may be the reason? What are the reasons for hypotension in this patient? What are the reasons?
One of the causes would be sepsis.
Septic shock, hypotension. Second
thing is patients are adrenal insufficiency.
adrenal is same thing. Sepsis, adrenal insufficiency, shock.
Then high PEEP in the
High PEEP, that is very important. You should never forget that. When you are keeping the PEEP high, there is a chance of hypotension.
So then patient is currently admitted under us. We are treating patients still on ventilator. Coming to ARDS, we have earlier the Berlin criteria of ARDS, which is now changed to the global definition for ARDS. So
He had one more thing. He had bilateral pneumothorax. So what is your differential diagnosis? ARDS is one of the reasons for bilateral pneumothorax during treatment. Other reasons?
One of the things could be because of already ARDS is there.
ARDS is one reason.
Ventilator was put on oxygen.
ARDS, when you are putting on NIV or high PEEP ventilation, you can get pneumothorax. Second reason,
PCP pneumonia is
PCP pneumonia is another important reason for bilateral pneumonia with pneumothorax. Third reason? Third is what?
Other bacteria.
Which bacteria?
Staph aureus.
Staph. MRSA, here you are telling. Staph aureus is the third reason. So, ARDS itself can produce. PCP pneumonia also can produce. And MRSA, that also can produce pneumothorax in this patient.
For that bilateral pneumothorax, we inserted bilateral axillary ventilation.
Okay.
Then coming to the criteria for Berlin global criteria for ARDS, basically it is any acute worsening of breathing difficulty within the last 1 week. Risk factors could be anything such as pneumonia, non-pulmonary infection, trauma, any transfusion, any aspiration pneumonia, but should not be cardiogenic. The cause should not be cardiogenic pulmonary edema. Timing should be within last 1 week. Then imaging could be either it could be a chest X-ray or could be a CT. And nowadays it has been added. It can also be an ultrasound imaging, especially in resource-limited settings. It should show bilateral opacities in chest X-ray and computed on CT scan. Now it can show bilateral V lines or consolidations on ultrasound, but it should not. Then, coming to the criteria that apply to specific ARDS categories, we have the non-intubated ARDS, intubated ARDS. So, coming to non-intubated ARDS, we earlier used to see the PaO2 FiO2 ratio. That is, if it is less than 300, it is going to be 200 to 300 mild, 100 to 200 moderate, less than 100 will be severe. Then, in case of nowadays, we again also can see SpO2 FiO2 ratio, especially in resource limited conditions. So in SpO2 FiO2 ratio, we have between less than 315. So 315 to 235 is mild, 148 to 215 is moderate, and less than 148 is going to be severe. Then in the case of resource limited settings, where we don't have APG, where we don't have any NIV settings, no HFNC, nothing is there. There we can directly take SpO2 FiO2 ratio less than 315, considering SpO2 less than 97%. Saturation is more than 90%, this criteria won't apply. If saturation is less than equal to 97% and SpO2 FiO2 less than 315, with ultrasound showing bilateral V lines, we can consider this patient with acute worsening of breathing ability within 1 week. We can take as ARDS.
HFNC
And HFN, high flow nasal cannula. Nowadays, in case we can also for all these criteria to be fulfilled, where we are taking PaO2 is to FiO2, there is a basal requirement of 5 mm PEEP in case the patient is on BiPAP. But in case the patient is not on BiPAP and we have put the patient on HFNC, then the flow rate has to be more than equal to 30. Then only this criteria for WHO criteria for global definition will apply.
So this will be the initial choice of treatment in ARDS.
Then once we come to the ventilator settings, here we go ahead with the tidal volume, which is low tidal volume, that is 4 to 6 ml per kg body weight is what we prefer. And it is dependent on the predicted body weight of the patient. So predicted body weight in case of adult male, the formula would be 50 plus 0.9 into height in centimeter minus 152.4, and in case of adult female is 45 plus 0.91 in height in centimeter minus 152.4.
His tidal volume is fixed from
4 to 6.
starting day to last day of treatment, or is graded?
Change.
You can increase.
And then ideal respiratory rate should be less than 35, with saturation target should be 88 to 95%, and PaO2 target is around 55 to 80 mm of Hg. Then P will start with 5 and will keep increasing, preferably up to 24, not beyond that. Then plateau pressure should be less than 30 centimeters. Then if there is, if you are not achieving tidal volume, then we can change if plateau pressure is less than 25, then we can increase tidal volume by 1 ml per kg body weight till we attain tidal volume. Then
What is prone ventilation?
prone ventilation is done when the patient is turned in prone position, where abdomen is not dependent, but it is the hip, the pelvis and chest will be the dependent area. It is usually done to increase the ventilation perfusion ratio, because posterior part of the lung is usually dependent. When we are in supine position, that is the part that will be collapsed because of the dependent resistance. When we prone it, actually blood supply to the posterior region is better than the anterior region. So when we prone, this blood perfusion as well as the ventilation improves.
Okay.
Also
Maximum lung
secretions-
volume is on the posterior.
side. Then secretions, we can secretions mobilization, then aerosol mobilization also improves. Functional residual capacity also improves. So it is preferable to prone the patient, especially after 12 to 24 hours after treatment. Proning can be initiated.
Okay.
Usually it is done for around 16 to 18 hours can be done. Contraindications to proning being any recent tracheal surgery or any sternal surgery, or if the patient is having is in hemodynamic instability, acute hemorrhagic shock if it is there, can't be done, or if bilateral ICT placements if it is there, it is a relative contraindication. Other than that, patient proning can be done. Then we have also other adjunctive therapies, like we can use inhaled nitric oxide nowadays, or prostaglandin infusions. Inhaled nitric oxide, usually you use a 5 to 10 parts per million pressure. It is usually given because it will increase the blood flow to the well ventilated areas of the lung. So thereby increasing the VA by Q ratio, that is the ventilation perfusion ratio, which improves, and thus oxygenation improves. Then we can, in case of that, if available, we can also have the epoprostenol, which also has epoprostenol. And if after doing everything, the patient is
Ideally, it should be started much earlier, but because of a lot of financial issues, it is delayed. But otherwise, it is a good option when we can start it early.
Then usually fluid restriction. Since patient has a tendency to go into fluid overload, we should fluid restriction should be followed in
What is
such
liberal
patients.
strategy and restricted strategy in this? Liberal strategy and restricted strategy. These all you are already told. There was two approaches. One that is give a lot of fluid and see whether patient improves or not. Then came restricted strategy. Now we know that our research shows that some restriction in the fluid intake can improve the length and dry up the length. And sometimes it can it can backfire because patient renal parameters can deteriorate.
Then other supportive care, we have to properly sedate the patient. There should not be any asynchrony when the patient is on the ventilator. He should not have increased work of breathing. Patient, in case needed, neuromuscular blockade can also be given along with sedation. Then nutritional support, glucose monitoring has to be maintained. Then nosocomial pneumonia prevention has to be looked after. Then venous thromboembolism prophylaxis, stress ulcer prophylaxis, has to be fever control has to be done.
Anything else?
Despite proning, if the patient is not improving, we can try other recruitment manuals, like carrier recruitment, where we will keep the PEEP of 30 for 30 seconds, which can recruit the alveoli. And also in ventilation, we can try airway pressure release ventilation, APRV mode can be tried. In pediatrics, we can try HFOV mode also. That's also can be tried. And we also try avictad, which is a vasoactive intestinal peptide.
So
Can
this is
also
like
be-
okay.
Open lung ventilation.
And in the latest one trial is the where acute hypoxic failure, HFNC shows a better decreased mortality rate and decreased number of intubation than NIP.
So initial treatment nowadays is HFNC, that is important. So we also started as HFNC for this patient. Once it fails only, we go for BiPAP or then ventilation. Okay. Thank you.